I just want to know if I should be having more tests, because when I go to see the oncologist, hematologist, he'll say to me, how do you feel? He looks at my test results, everything looks wonderful except for my tryptase levels. Those are the ones that are all over the map. They've ranged from 237 to 720, and they don't just go up or down, they go all over the place. So should I be having this JAK2 test? Should I be asking him to test me more, or do we just leave
You said you had a bone marrow biopsy about a year and a half?
I had the bone marrow biopsy when I first went to the cancer center, which was about a year and a half ago, yes, and there was bone marrow involvement.
And then when the pathologist reviewed that biopsy, they didn't comment on any other problem with your bone marrow, just mastocytosis.
Yes.
Yeah, so I think that most experts do not recommend continuing doing bone marrow biopsies over time unless you really have significant differences in your symptoms.
Which I don't.
If you're feeling great, I think that following the tryptase is really the best thing that they can do for you. Unless you started developing some problems with some other organs. If your blood count started going down, if you're having other symptoms.
So as long as the rest of the blood is okay, which it is, and the spleen, I've had 2 episodes of the spleen being enlarged, and when I had one, he sent me to have an MRI, or not an MRI, a sonogram, and they saw nothing except that I have an abnormally large spleen.
I don't think that there's any other testing that you need to have. I think that with the medication you're taking, if your symptoms are being well controlled, then that's great news, and I think it's probably doing the right thing at this point.
I just got a little nervous when I saw those criteria, and that if you have more than one, which I do, I have an enlarged spleen, and I have very extremely high tryptase levels. Doesn't that indicate aggressive disease? Where am I? That's what I want to know. Is it indolent? Is it aggressive? Is it heading toward aggressive? What is it?
Could she go back on her bone marrow and test for the JAK? Like, you can go back and test for a CD25, or you can go back and test for. Can she go back?
Oh, with the same slide, you mean?
Yeah, on that same for the wax block.
So JAK2 mutations, they test it using the fluid that's taken from the bone marrow. You can also do that from the blood, although it's not as sensitive. But you can't do the JAK2 mutations from the biopsy and the paraffin block because it's not a good test.
How do we, as the common person, make sure that they're looking for the right sort of stuff? Like if there is another blood comorbidity with that, how do we know if most of our symptoms are just what we relate to masto? So
I think that a good hematologist, if you're seeing anyone outside of, I don't even know what specialist you've already seen, but if the blood counts in your white blood cell count, your platelet count, if your red blood cell count level, if you don't have severe anemia, then the likelihood that you're going to have one of these disorders that Dan D'Angelo and Jason Gottlieb were talking about, the myeloproliferative disorders, it's almost impossible. It just doesn't happen without having these, what people describe as, cytoses, where the counts from your blood are very, very high.
So those would be the red flags, basically.
And that's a great marker.
Check to see if
when patients start having these incredibly high numbers in their blood test, in their CBC, then that's a clue for a hematologist or an internist that there may be something wrong with your bone marrow making too many of those cells.
And not the tryptase. The tryptase would not be a marker.
Not at that level. No, that's really mastocytosis.
So you wouldn't suggest going into any clinical trials either, unless you were, anaphylactic all the time or had an associated disease. I've been in clinical trials in the past. I've been on dasatinib.
Yeah.
Dr. Verstachek has poked me many times. And I've been on ONTAC, and I've been on RAD 001. And we were talking about this one that Gottlieb has, but, you have to be half dead, really. And I'm not half dead yet. Would you think that I should just kind of, Dr. Costell's recommended that I go into it? I just saw her the other day, but I don't know if it's worth the chance at this point in time when he's only had 26 patients. And what is your feeling about it? If I'm generally healthy, pretty much.
It's a hard question for me to answer. I mean, I work with Dan D'Angelo, who was the last speaker. So
right, and that's
so I
what
see a lot of the biopsies, but I don't see the patients for whom he's considering who are the ones that really should be considered for these trials. So I don't think
and
I can
she
answer
recommended
that
that we, that I go to him.
Yeah.
But after listening to their talk, especially Dr. Gottlieb, I have second thoughts. He's pretty morbid.
Yes. But just as you said, I think often when these types of drugs are first being tested, patients have to be so sick, just like you described, to even be eligible. And
Right.
if you're healthy enough, then you probably won't be eligible at this point until it gets approved for
Right,
for
until
the
they
worst
do the
type-
randomized in
or
Europe
just worse
and
disease.
yes, exactly. But since you're also talking about cutaneous, have you got suggestions to help relieve the itchiness other than hydroxyzine? Anything that can improve the looks? I mean, it keeps getting worse and worse and worse.
We don't have an awful lot of the sort of things we use under the antihistamines, and we don't. The high potency topical cortisons haven't really been very effective in terms of treating the spots.
Oh, I did the Diprolene Rapid.
Yeah, I've never found that.
Oh, yeah,
I've
for a
never
couple
found that
years.
to work. It's about 15, 20 years ago that people started doing that. I've never found that to work. The only thing that sometimes you may get with the topical cortisons is one of the things that cortisons in the skin do is they cause a vasoconstriction and make the blood vessels constrict. You may feel symptomatically better for an hour with that. You can use things like Sarna, which has got camphor in it. Other than that, a fraction of people actually surprisingly do get some relief of the cutaneous symptoms with cromolyn. You wouldn't think they would, but they do. Ketotifen tends to be reasonable.
Well, I
actually,
take
as well.
sodium cromolyn.
How much do you
In
take?
fact, 4 ampules a day. Should I?
You know,
Just go up.
higher, or ketotifen is a reasonable thing. You should ask Mariana.
How about putting it on your skin?
I've never found it to.
I tried
be
making that
particularly-
cream that they
the
talked about that
4%
didn't
cromolyn
work.
cream, I've never found that to be helpful, but
It didn't
I know
work.
anecdotally some people like it, but I
What about PUVA or other UVB treatments?
PUVA works nicely. It's a question of whether you want to do it because of the
Those are the risk
long term.
factors, yeah.
I mean, you do.
How about going to the beach?
It's great.
I live in Hawaii. Can I go to the
What we don't know is how well. What we don't know is how well narrowband UVB works. It probably is also useful as a sort of a substitute for PUVA. PUVA would certainly be better, but you get the funny tan, you get to wear the glasses for a day, and you get the increased.
See, I've done the
cancer risk.
narrowband, but not the actual.
Did
I
the
haven't
band-
medicated with it with the PUVA.
Did the narrowband help?
I really couldn't tell a big difference. It was almost like I was 19 and had laid in the tanning bed a few times.
How many treatments?
I went 3 times a week for almost 4 months.
Yeah, so that's probably a long enough trial. Yeah, so PUVA would be the next step as to that. Yeah.
I'm going to interrupt one more time. And
That's okay, I'm done.
As far as new kind of tries of new technology and things like that, do you have any research on hyperbaric chambers and whether or not those have been effective?
Couldn't
No?
say. Couldn't say it's not. Just don't know.
I'd like to see. You never know if
Yeah.
that would be
Yeah.
something positive in the future.
That sounds like
From the
something
point
that
of
would
view,
set me off.
as the spots age, oftentimes you get they get more erythematous, they get redder, and they have more discrete blood vessels in them. They'll have more vascular ectasias, and I think some of that could be the effect of the mediators and stretching of the vessels, and some could be the effect of mediators and just anyway, you get more vascular ectasias,
Right.
and those would be very amenable to pulse by laser. So the background redness could be done that way. The TME, lots of times you have people who have something that gets diagnosed as TMEP, but it's really urticaria pigmentosa with some prominent vessels, and it's the redness that bothers people. Those could be lasered. Yeah.
So with the TMEP or with the UP? Or either one?
TMEP certainly could be lasered. If you had a prominent vascular component to the UP lesions, those could be lasered. Or, for example, if one had it on the
Wait,
neck.
are you talking about these broken veins all over my... I have gone to a doctor, and he said he couldn't do anything about that because it was all mast cells in there. You know, all these
You could laser
broken
something like
veins.
that and see how it works. I mean, we'd get rid of the redness. It wouldn't do much for the mast cells, but it would get rid of the redness.
Yeah, the only time they disappeared was on dasatinib. Okay.
I have another question. I was diagnosed last year with meningioma on my auditory nerve, and I was wondering if you feel that that has anything to do with mastocytosis.
No, I think it's just a coincidence.
Just a coincidence, but someone said that meningiomas are filled with mast cells. Is that true?
Many different tumor types, benign tumors and malignant tumors, can have mast cells sort of scattered about, but you also see mast cells in all the normal tissues in our body. There are mast cells there normally, so I'm very certain there's no relationship.
So it's really a very elementary, basic question, but with the systemic mastocytosis, when you have lesions, that's not the unitary pigmentosa. That's not the unitary pigmentosa, right? The UP.
The UP?
Yeah, having lesions, when you systemically have lesions, that's not okay.
Well, urticaria pigmentosa is called the skin lesions, so it's cutaneous mastocytosis.
Oh, and it's both that.
Some people just have UP, and some people have UP on the skin, and they have systemic.
Okay, so even though I'm not like, well, I can get, I mean, when I granulize, obviously I get real red, but on my, I always have these lesions that are on my thighs, on my arm. So that is...
Yes.
Okay. Because I was then going to ask, if it's not, does something bring them out or bring them on, or, you know, as they multiply, you know, like one day I remember waking up and I'm like, what's wrong with my thighs? You know, because you wear bathing suits in Tucson. And I was like, that's kind of bizarre. I mean, I thought maybe as you get older, you get spots, right? That's originally before I got the mastocytosis, that's what I was thinking.
So why do you get more of them? I don't think we really know why it runs that way. And it's interesting because, you know, in ancient times when I used to first see patients with masto, 25 years ago, you'd see patients over time, and lots of times the lesions would disappear over, a decade or so, but the systemic symptoms would be exactly the same. They seem to be on different tracks. Haven't you found that? I mean, it's an interesting thing, and of course, we don't know why that is. I mean,
Could you speak up a little?
Oh, we don't know.
Yes.
We don't know why there's sometimes resolution of the cutaneous lesions, despite the continuing presence of elevated tryptase levels and still having GI symptoms and so forth. So it's hard to know.
Are they more common in our friction areas, though?
No, but what brings them out? Why are they more symptomatic? Friction,
For mine,
hot
with mine, because mine
shower
are different.
alcohol,
They're different than mine.
Yeah.
Mine are all the abdomen. And,
Yeah. And I'd be out there for like 4 minutes, and I'm like itching, and they're swollen, and welting. I'm like, what is wrong with that? And then I thought, well, I guess I'm older, got the spots, and maybe I have sun poisoning. You know, like my mom had sun poisoning as a younger woman, so maybe I got these issues. I never knew until probably 7 years.
it took about 8 years for a doctor to figure out
I didn't even
after
know there
those
was anything
same
wrong with me. I thought it was
symptoms.
normal. I thought I was just getting
Yeah.
older.
But they can be very, the appearance can be very protean. Some people can have just something that's tan, that looks like just tan, with not a lot of substance, pretty flat, not a lot of substance. And other people will have the more classic, slightly raised reddish-brown spots. So I mean, it doesn't always hit you over the head with it. And it changes with time.
And one more question, speaking we're talking about changing over time, and I did have these long before I started dropping. I heard somebody who had been associated with the society for a long time, the Master Society, she said that when you were born, you most likely had this. And I've never heard that. Do we carry this? I mean, do we have this at birth, and then it just manifests itself in its 40s, or?
No, so there are definitely a lot of patients who only first manifest any aspects of disease when they're adults. It's 70 or 80% of all patients are children, so it's much more common for very young children to first develop their skin lesions.
So like having a bad bout of poison ivy as a young woman or a girl has nothing to do with it, or?
Not that we know.
I don't think anybody knows. I mean, was it all that morphine they gave me in the hospital when my daughter was born?
Bad luck,
You
a
know,
viral thing. Why
you
do we
know,
get a
who knows?
somatic mutation?
Yeah.
Basically, yeah.
I thought it was my pregnancy that kicked off a whole chain of autoimmune diseases. I had polymyalgia rheumatica, I had iritis, I had undifferentiated connective tissue disease, and I was on long periods where I had to take prednisone, and all of that has disappeared. I have no more joint pain. I don't get any of those things anymore, but now I've got this.
Yeah, we saw
I don't know if that's related or
We
not.
didn't see it last year.
We don't know.
I was there.
Yeah,
We were there on the break.
I did hear that people who start with the cutaneous form and then it morphs into the systemic form, so less likely to get a really aggressive form. That's
No, when I was diagnosed, they told me I had cutaneous. Never be anything else. It'll always be cutaneous. But then, I mean, I've got aggressive now. So, you know, what you can't have a blanket statement like that because I don't.
No,
With our disease, it could be anything.
Definitely.
But then you're talking about the cutaneous kind of being on a different track, which I find very interesting.
The way the lesions behave doesn't correlate with how GI systems like that here. Other issues.
Yeah,
They can
because
resolve, but people still have
How does a chef go counter nutrition?
My doctor praised me because when my spots, I'm just glowing with it.
I don't know
My
what
symptoms, symptoms don't seem to be that bad. And then they'll clear up and I'll look fine, but I'm sick as a freaking dog.
well, the doctor who told me about the veins and not being able to do anything because they were clogged with mast cells, he said, oh, he had a patient that totally cleared up from the cutaneous. He was a dermatologist, of course.
well.
And, but I don't think she ever had systemic.
2 years ago, it was I've been very, very sick. Finally, I'm
I think that somebody should be afraid, and speaking as someone who doesn't always, I can be
I don't want to overwhelm you with a lot of questions.
I don't mind.
I know
And
you're on
feel
the-
like,
the
I also feel
lab
like I can't always answer them, and I feel awkward not being able to tell you very much because I work with all the doctors that help take care of you, and I help with making the diagnoses, but I don't know a lot of the subtleties of treatment, so I can't be very helpful with that.
So you don't actually deal with patient-to-patient contact. You're behind the scenes.
Yeah. I'm like a consultant to all the
you know,
other
and of
doctors,
course you hear people
and I help
talking about
teach them about the
prednisone.
diseases, but they're the ones with the
And I've been
expertise
on
in
a lot of
treatments
prednisone.
and knowing what the best options are.
And now I'm getting the side effects from it.
Do you know about the neuropeptide?
Cataracts. I'm pre-diabetic.
No.
I'm, you know,
I'm trying to figure out what that
a whole
is.
list of things. And my circulation doesn't
Dr. Theo had mentioned it, and I didn't know
if I
exactly
have
what
to
that
mess
was.
with
Well,
that,
you know, mast cells have so many different
heal as
chemicals
well,
inside of
basically, is
them.
what you're
And
saying.
when they release those chemicals, they can have so many different side effects in your body. And I think we're really still only learning about what they trigger, what are the different
I
things that
have
can go wrong
no
because of those
idea.
chemicals.
And it does make it harder because we are even though we share that commonality, we are so different
Yes.
in our triggers and
I have a question. There. I got in. All right, I was diagnosed by skin biopsy, then went to NIH, bone marrow, systemic. I asked Dr. Wilson, who did my bone marrow biopsy, does it mean if you get more spots, is the disease getting worse? He said no. I don't want to say I don't believe him, but I want another opinion.
most people.
What do you think about it?
Like I'm getting more.
Yeah. Well,
Me too.
For most people who have cutaneous mastocytosis manifested by keratokeratosis pigmentosa, the number of spots. I mean, it doesn't correlate with the disease. Most people, it does what it does. Just having more, but in the people who get systemic mastocytosis, having more cutaneous involvement probably tends to be associated with worse systemic involvement. That is, probably tends to be associated with worsening systemic disease. Most people who have the skin involvement, though, don't have horrible systemic disease. But if you do have systemic disease and you've got the skin involvement that's getting way worse, probably there's a good chance of it, being worse systemically. But you could monitor that with symptoms and, tryptase level and so forth. I mean,
My tryptase went up a little bit this year.
But I went from being never having anaphylaxis to where I've had 3 episodes in the last couple of years.
Right, okay.
So to me, in my mind, it is.
I think these blood.
Plus, I've got more stuff.
I do.
And my tryptase.
I get them on my phone.
Oh, I do too.
It is a good to follow healthy and producing all the cells you want. A little bit.
Who's got them on her face?
I got them on my face.
I think my
face is as red as Michelle's.
I don't know if I have it. I don't know if it's because I'm getting old.
But again, you can have
That's what I would say.
Oh, you're sucking up really good, girl.
I don't know what a good
Not.
result would be.
Not kidding.
She's so fascinating. And I think that's why so many doctors become fascinated. Because that's true. That's
The whole
true.
concept of where to place the disease related to
I mean, I wouldn't say anaphylaxis. It's just,
there are many,
and he had known I had the disease, but living where I do, I don't have as many of
the cells are derived from the
exposures to
same donor cells that make
and then just sat there, I was,
blood
didn't
cells.
have thyroiditis
Because of that, since
involving and it's gradually been getting worse, and then I have anaphylaxis, and all of a sudden my
in
doctor
a very broad
goes,
sense with an MPN, with a
"Oh,
proliferative
I'll pray for you."
I think that most people who sort of
because he
study the
didn't have a
biology and the
clue.
genetics
He
would say,
really
yes, it is an MPN, but it's a very special type, right? And most patients with
But it's
systemic
everything's
mastocytosis
coming back.
develop other forms of myeloproliferative neoplasms.
Well,
Some do, as you heard at the end of the day.
I want to get back to Hawaii.
Yes, all these things. Yes.
That's a new trick my body is messing with.
Yes.
So, isn't it an MPN?
Yes, yes. It's a special sort of, it's like a unique form of
They
MPN.
did is that you still have to wear the protective eyewear, and they want to
Right,
make
and
sure
I think
that you protect from glaucoma and all that. But it made me feel, my skin is uber sensitive, even worse, and it made me feel like I was
Which is a good thing.
and you get like a little fan.
And everything else.
It's like a stand-up internet.
Really?
So you get in there
And you're
and
standing?
And you communicate with the.
well, that's the first time I went in. I was like,
We can get you
do I completely undress? So I didn't. I left my underwear on. And I got out and I got home and I'm like, getting my shower and stuff, and I'm like, what? Because then it's just like the internet. I had the lines and everything on me.
Oh, wow.
Remind me later. I've got pictures of in the bed and stuff like that. Because there was some go in.
So do we have to request anything special as far as a blood test? It would show up on a regular. Okay. Well then, if you haven't had a bone marrow biopsy for almost 5 years, it was 40%.
And then it's my right. So
What it is now, because it worse. Do you suggest that I
I do now sometimes, and
when they
You
get
got one, or should I just kind of just
That's because I'm really,
hang out?
Yeah, it's I grow Zilla something better than
I got it up. 8.
it's not, like your first couple of treatments. I know the first couple, I got in there, and I'm like,
know that. I know.
but the machine went off. So I got out, and I walked in there. I'm like, the wrong button, and she's like, literally only in there for like, and she's like, she's like, the longest I think I was in there, probably not more than a minute. I don't even think I was in there almost 6 minutes. No, just the nervous,
I think that
I
what
remember
That's probably.
before I got
Val
diagnosed.
was sort of referring to is there are patients with
Right. No, I have my statistics all the time.
all the
But, you
problems
know,
with difficulties
try to cover them up.
specific, all the problems we have
Right,
with all the
exactly,
symptoms
because
What?
are not because there's so many cells filling your body, but it's those cells are just releasing all their stuff that makes you feel sick. And it doesn't cause problems that are not due to that. It's not like, so for some patients with the indolent side of things, they don't fill the marrow and exclude all the other cells and cause problems with all your blood counts and things like that. And I think he was referring
Exactly.
to
I already know they're
some
there.
patients will progress to a more aggressive disease where you have problems maintaining your platelets and your red blood cells. And
Exactly. That's what I'm
infections, or you
thinking.
have
What can I
really
do?
bad skin
I mean, I can't except alleviate the symptoms
I think that's
the
what
way
he
I've
meant.
been doing, adjusting medications.
I have, but not a lot.
See, I get those too. I get them on my legs, my toes, yeah, that's really.
I got it forever.
It's the elephant in the
I
room.
got on my
In the sense that if you
thighs,
present
Yeah.
tummy, breast, my back, butt.
Everywhere.
I have
more
it.
likely to have a bad type
That
of
was
disease,
not
but my red blood cells are low.
almost
That's the only difference. It's very much narrow. So it was like, not too big, because someone said, oh, just too many. So it was like, they would say, you know,
I think for all the clinicians, whatever specialty who are taking care of patients like you guys,
Well,
it's a
that
very
was what
difficult
my
decision
problem was
when
all
do
those
you move
years.
from
I was
treating all
going
these bad
to
symptoms
neurologist after having a Kaiser primary physician, not
Because
knowing
the
what
last
it
two
was.
lectures, obviously, these
And
are
it really wasn't
treat
until I
patients
was
with the most aggressive
in
form of
ICU for
disease.
3 days
Those are the
that
drugs
I
that everyone's
found
sort of
out
talking
that
about.
everything
Should those drugs be
covered
used in
with
patients
mast
who
cells,
don't
and I
have
was referred to
very aggressive disease, but the symptoms are really bad and they're not able to be controlled by
you know,
the medications that you take?
but if you can't,
And we're just not
I've been on enough trials that I know that it's fun, but if you
I always joke
statin, it
around.
almost
Yeah,
worked
that GI problem.
until I got PCP.
You're like, IBS, whatever.
And it's a really horrible pneumonia.
What are you kidding me? You know, I mean, I couldn't even leave my house.
Right, exactly. And Dr. Lee was, you know, he was just so excited to get some animals. It's like, I've got another one for you.
I was saying that my oncologist really was only treating
Yeah, sometimes.
Oh, get set now.
I'm not on that.
I was on
I see the same doctor in and she's recommended taking that. Thank you.
And so he's doing my CD25 pretty much.
But I haven't tried it.
So that was the last one you wanted.
I thought she wanted me to set up.
Late teens I never had.
So,
I had
but
somebody
you had some cutaneous symptoms, some mediator symptoms, some GI stuff.
I never. They were like, and then GI reports and ideas. They said I had problems.
So mediator type stuff, that plus the skin and the bone marrow.
Almost there.
Every year,
I'm like, really?
you know, yeah.
All my skin. My skin.
Yeah, I mean, unless something changed, got
Switch to another group or take advantage of another opportunity to speak to different physicians, you should think about moving
every
now.
3 months, maybe the right answer is every 6, but
So what?
I do every.
I'll give them every 6 to start it.
All right.
Just to be fun.
Kind of getting worse.
So what if I wanted to send my information,
How can you even tell if it's
my aspiration bone marrow? What if I wanted you to look at it? Like, what if I felt like you were the best and I wanted you to look at it? How would I find it?
So you can certainly do that. We
See, I live in Georgia. It's very rural. People are very just, you go in and like, I went into shock. I told them I had mastocytosis. They said, which breast is it? I said, no. And they said, you have mastitis. I said, here we go. It's going to be a long road. But I'm having a hard time finding good health care down there. And I've gone as far as to Duke, and I see a doctor at Duke, and she's been really good. But again, not a lot of patients, not the right information. So I'm having to be my own advocate as far as test for this, send it here, do this. And I mean, I think I have to be proactive in my own health in order to get the right treatment. So.
I mean, I've only been working with Dr. Aiken and Dr. Castell, so I know their experience, and we meet every few months and we discuss difficult cases and we discuss updates in the field. So I look at biopsies of all their patients. You know, I don't ever see patients; they're the ones who see the patients.
Right.
So, but in terms of pathology opinions, I mean, certainly we review cases from all over the world for a second opinion.
Okay.
And if the diagnosis is pretty solid and there's not a lot of doubt in the diagnosis by your doctor or by the pathologist and doctor working together, then I often think it's not really necessary to get another opinion.
Okay.
But if they really feel like there's a lot of doubt about the diagnosis, then certainly I'm happy to review it. A lot of people do, things just like that. And it's very easy to get a second opinion for pathology, and most insurance covers that, so it's usually not a big problem in terms of insurance.
Will so if I go to Duke and they send it off, under the assumption that they're looking for the spindles and everything like that, are they going to do everything they need to do with that marrow? Do you see what I'm saying? Because I don't want to have it done, 3 months later, we didn't get enough, or we didn't do the right test or something.
So most major centers who treat patients with mastocytosis, their pathology group would do all the right tests.
I have
They would do the
systemic
appropriate tests.
cutaneous.
It's just kind of a fear,
Of course. And some of the markers were developed pretty recently. And I mentioned CD25, which people talk about all the time. And that's a relatively new marker. We've known about that for maybe almost 10 years, but widespread availability of that marker hasn't been. It's pretty recent. So even in our laboratory, we've only been offering it for a couple of years now, so it's relatively new. And certainly I think there are a lot of pathology departments that might not have that available.
So if my referring physician does it, can they request the CD25 or
yes.
whatever?
Yeah, so your doctor
To have that additional stain done.
It's not always required if a bone marrow biopsy shows involvement by those aggregates that everyone talks about, aggregates of spindle mast cells. If you have a high tryptase, then the diagnosis is not in doubt. So you've made it. You have the major criterion, you have the minor criterion, and we know it's systemic mastocytosis. So it's sort of it's a part of the puzzle. It's like another thing you can kind of cross off, but it's not always necessary for a physician to feel confident in the diagnosis and to know how to treat you properly.
Anyway,
and they would run that test on both extraction from the bone marrow. Would they also do it in the biopsies from the GI and things like that, or is that okay?
Although most laboratories haven't been doing that. That's also quite recent. I mean, I've only been studying that for 3 years now, so it's a pretty new thing, and you can definitely do it on a biopsy from anywhere in the body. All the experience in the world is to do it on bone marrow biopsy. biopsies, but you can do the same types of tests
certain
on a GI biopsy if you have
that way,
colonoscopy or an endoscope.
Many years
It's,
ago, the
it's
guy
really,
who was
it's
the
just as easy
sort
as
of
the
the
same thing.
godfather of
Okay.
Although many
disease,
patients who have
really
systemic
delineated
mastocytosis, even if you have really severe GI symptoms,
people who
many
have
patients don't have the cells in their GI tract. The symptoms are because they have all these mediators that are released by the
but not
cells.
everyone's like that.
So histamine and everything else that you hear about that you take all these medications for, that's the culprit. That's why you have pain and diarrhea and everything else.
That makes sense.
I mean, I don't drink, I'm not drinking a
We
lot
don't know
anymore,
how often
but I enjoy a good
the
glass of.
symptoms are because of both. It's because of the mediators like histamine
I have
and that
colitis,
the
which
cells
I've
are
had
actually growing in
forever.
the lining of your
And-
GI tract.
Okay.
We don't
Yeah, I had a
really
glass
know.
of
We
wine
definitely
2
know it
nights ago,
happens
and
sometimes because we
really
can make
great.
that diagnosis, but it's not
So
always
it's
the
like,
case.
As long as,
Thank
you're
you.
aware of what your reaction is historically.
I have recently been diagnosed.
As always, you
but
know,
my
you're going to have
allergist who
Benadryl, you're going to have
diagnosed
EpiPen, you're going
me
to have
on
those
tryptase
things.
level. Back in January, I was sent to a path.
I live in Boston, so I always
Oh,
feel
yeah.
guilty taking up doctor's time because I'm right here.
You're right here. You're right here.
Took lots of
With our
blood,
fine
lots
weather.
of the urine tests and all of that. And he, at that point in time, said that he did not see any indication in my other workup that that he would recommend a bone marrow biopsy because he didn't feel that my treatment would be significantly changed if I had a bone marrow biopsy based on he didn't see any other things that were going on in my blood. I mean, is that, I'm not trying, I don't know, I just know that what, everything that has been said here, that you can't just use the tryptase levels in order to diagnose mastocytosis.
How high were your tryptase levels?
My tryptase levels are between, they have varied between like 25 and 50. I just don't know if I should push for a bone marrow biopsy.
I came in on the back end of it. What sort of clinical presentation are we talking about?
I have suffered with lots of GI issues all long time, plus other very strange allergic things that have happened in my body. There was a period of time that I was allergic to water, not on my skin, but it lasted for maybe 6 months, and no one took me seriously as to the issues that I was having with taking showers. And there's just been other things that have taken place. What recently caused me to be diagnosed was violent episodes of vomiting and diarrhea and flushing from head to toe. I mean, just, I didn't know you could turn so red.
And the tryptase levels are 50 or thereabouts, and that's all the time, not even just after an episode.
Correct. Those are, what do they call those, baseline?
Okay.
I mean, I just had one done.
But no skin involvement.
Well, I don't know. No one's ever looked at my skin. I do know that when I have gone for I also have allergies, and just recently found out in November, lots of food allergies last November. And so I was hoping that a lot of the GI involvement was the food allergies. But they've always said that my skin is very sensitive, that, when they start pricking me, even very little at all, I turn red.
So we don't know if you have skin involvement,
Correct.
But you do have some GI symptoms that would be consistent with, and you have a tryptase that's moderately elevated. So the first thing would be to look at the skin. If you had the spots, then there you go. If you didn't, it would probably be reasonable in that setting to get a marrow. I would think, what would be the reasons for doing one? One would be to try to make the diagnosis of the disease, and you'd have to, so you don't make it just on mediator-based symptoms, you'd make it, or on biochemical elevations, you'd want to have a histologic, a pathologic diagnosis. And if you can't get it in the skin, then the marrow is a reasonable thing to do, and I don't think it's not a horrible procedure. The question, of course, would be if you had it in the skin, if somebody did a skin biopsy, you had cutaneous mastocytosis, and you have GI symptoms consistent with an elevated tryptase, you then get a bone marrow biopsy. What do you think? What do I think? So,
Yeah.
What do you think? You're the
I have lots of purples and moles and stuff. I have all of my life, even as a kid. I mean, you know, you can see lots of.
So I think that most, if not all, adult patients who present with skin lesions of urticaria pigmentosa when they're adults and they never had them as a child, most of those patients have systemic mastocytosis, which may be very, very low level involvement of their bone marrow, for example. So for that reason, I think if you're not having many other symptoms, and if the symptoms can be treated well by medications, it's probably not a requirement to get a bone marrow biopsy. I think in a way it's sort of an optional thing, and I'm sure that a lot of doctors, a lot of hematologists would say it probably isn't needed, and others, and certainly if you were seeing a group that works in a mastocytosis center that's seeing many, many patients, I think they all would recommend a bone marrow biopsy just to kind of give you a baseline so we know you definitely have systemic disease, we know how many mast cells are in your bone marrow, and over time, if your symptoms did get worse, there would be something to follow, some sort of reasons to treat you in different ways. But I think if your symptoms are manageable, and if, as has been mentioned, if they can document that you have skin disease, then I think the bone marrow is probably not, strictly speaking, totally required. I think it's a bit of an optional thing.
And would it be best to go to a dermatologist in order to look for that?
For skin involvement, definitely a dermatologist, yeah.
Okay.
I think that general practitioners don't have the expertise to know some subtle skin findings to make the decision that it is urticaria pigmentosa.
If there are no persuasive lesions and if there's nothing to do with skin biopsy on, and again, we don't like doing and you don't want to do is just do a random biopsy of non-lesional skin because you don't know what that means when those come out. But if there are no lesions amenable to a biopsy, then a bone marrow. 20 years ago, I think, when we had people with symptoms and skin involvement and skin biopsies, we liked doing marrows on them because a poorly understood or disease you want to try to delineate. But the $64 question would be, is there something you're going to treat that you're going to find out about with that marrow earlier? And many hematologists will wind up saying, nah, you're going to find it in the blood count and systemic symptoms if you're watching the patient. But still, information isn't bad if it's, it's easy to get.
I will say, I had a bone marrow in 98. I have cutaneous, I was born with it. Anyway, in 98, they only stained with the blue stain, and everything was negative, but all my symptoms said systemic disease. So she said I was borderline, even though all the stains were negative. Now, 4 years ago, I had tests with Dr. Butterfield, and I'm Cicotte positive, JAK2 positive, I have aggressive disease. Bone marrows can change over time, but now that there's really great testing, if you have it, you're going to get the genetic testing done, so you'll know. But like he said, unless you're really, really sick, there's no need to do it now. Back then, they did it all the time. They did bone marrows on cutaneous patients all the time. And it wasn't until my third one that they got it figured out, but that's because the testing has evolved so much. So it's really symptom-based, and I can account for that. It's very, very symptom-based.
Well, I'm hoping to get an appointment up here. I just haven't been able to get all of that together, so thank you all.
Just ask a very simple question. Cutaneous. My husband breaks out, it gets very red. He has the flushing. His blood pressure plummets, it skyrockets, he throws up, he has diarrhea, he passes out, his throat closes up. He's had a bone marrow test about 12 years ago. The doctor said he had systemic mastocytosis. But when he has, usually across his belly this way, when he has one of his attacks, it's just like purpuremia. And they're sometimes over his whole body. Is that what cutaneous mast cell disease is? I'm confused. Is that what that is?
So what does he have? What does it look like?
It's like purpuremia.
He has purpur. He has just the
Purpuremia.
spots that don't blanch when you hand over them. Or if you run your hand over
They
into
eventually
the-
go away. It looks like he has shingles when he goes to the hospital. It looks like,
It's very red.
yeah, it's like little
And
purpura.
when he's not having an episode, does he have spots or no?
No, he just has red flushing all the
Good
time.
question. So that's not the classic sort of skin stuff, although he might have some subtle mastocytosis in the skin that that you're not really appreciating. So it's possible. It could be either way. The throat closing is what you also want to do with it is surprising to me that
He's only had that twice out of 30
that
times.
an upper respiratory obstruction isn't really a symptom of mastocytosis. You would think it would be, but it isn't, unless the person also has some other allergic problem. So, so you want to think back or look at those episodes to see, was there something else? Was there a food, a bee sting? Was there something?
He was tested for all kinds of foods. He's not allergic to anything.
But the typical attack isn't going to involve that. But if you have mastocytosis and you have something else that is going some immediate type hypersensitivity reaction, some allergen that's going to cause those mast cells to degranulate, yes, then you're going to have a worse allergic reaction than someone else will, and that could involve upper respiratory
He only has
obstruction.
the closing of the throat twice.
Yeah. So there was something else with those episodes. Could we but no?
Pardon me?
So there was something else with those episodes. Could we but no? There was something that made those episodes special.
So they're not anaphylaxis then?
They're anaphylaxis, yes, by definition.
But they're not just due to the mast cells, and
If there's
you're
upper
saying they're
respiratory
allergic.
obstruction, look for an allergen also.
Really?
If there's a what?
If there's upper respiratory obstruction, look for an allergen as a compounding factor also.
But the majority, like I said, 28 out of the 30 times we went to the hospital, it was the diarrhea, the throwing up, the passing out, the blood pressure. And he usually has hypertension. One time his pressure was 60 over 40, but most of the time now, by the time I get to the emergency room, he's awake and his blood pressure is way up there.
And that's all anaphylaxis too then, what you're just describing.
Pardon me?
That's all
Oh, I
anaphylaxis
know
too,
it
what
is.
you're
Oh, I
describing
know it is.
too.
I know it is. So I just didn't understand. He's never had lesions that I know of, except he was looking at one of the pictures today where they had a hand and there were two little bumps, and he said to me, I've had that before. He didn't know what it was.
And I think what you're describing, a lot of these red patches, that's probably not the cutaneous mastocytosis. That's probably when he's having these reactions. He's getting this flushing.
He gets purple, I think. So the little purpropenia, isn't that part of it? Because that's when he gets those, when he passes out, he has the diarrhea and all 9 yards.
It's probably part of the blood vessels dilating as part of a systemic reaction, but there may not be the little mast cell tumors that the little urticaria pigmentosa spots, the little mast cell deposits that we think of as being cutaneous mastocytosis. So hard to know. Have to look at it.
So it could be two different, you're telling me two different.
Can you, I have a question, can you have cutaneous mastocytosis and have a Cicotte mutation be able to be PCR'd out of your bone marrow?
So I don't think they've found that. In the patients who have purely skin disease, and if they do a bone marrow biopsy and there's no evidence of systemic mastocytosis, I don't think that they've found a mutation in the bone marrow.
Okay.
There are
It's just in this, it's just restricted to the skin then.
Right, but patients who have cutaneous mastocytosis, they can have a Cicotte mutation in the mast cells in the skin. And there's a couple of different mutations that have been detected. There's the classic one that you've heard about in almost every lecture, but there are also some others that have been detected much more commonly in young children.
So if they, 12 years ago, if it wasn't a mastocytosis doctor that had asked for the bone marrow to be looked at, they didn't do stains like they do now?
12 years ago they did. So we had some of these stains 12 years ago. We did not have the stain CD25 that people have been talking about, but the other stains, Cicotte and tryptase, those were around at that time.
But it depends where they had them. I mean, I just had one a couple of years ago, and they didn't stain for any of that stuff.
Well, this was a
and it was an
carcinoid
aspirate,
cancer
not
doctor
a
that
biopsy.
referred Bill to another doctor who did nothing but took bone marrow test, and he said you have carcinoid cancer. I mean, not you have mastocytosis, not carcinoid cancer. So.
Right. Yeah, in most patients, it's not difficult for a pathologist to see the bone marrow lesions, you can see these little circles that are all these spindled mast cells. So
They're not circles anymore,
no, I don't mean the individual cells. I mean like you can actually see a nodule that has many cells that are all kind of grouped together in a clump, and it's not that hard to see them if you see a clump of cells. The difficulty is when you have very few cells and they blend in with all the normal bone marrow cells. If you don't do a stain, then you won't see them. But most patients have the first situation where you'll have a clump.
And you said that we possibly could still get a hold of those and have them sent to you to have them be
Right,
stained.
but at that time, did you say the diagnosis of systemic mastocytosis was made? Yeah, so it sounds like they must have seen those clumps of cells. So at that point, doing the stains aren't really a requirement. It's only when it's a very subtle finding and the pathologist is really struggling to see them, where if you hadn't done the stains, you could easily miss it. But if you see these clumps of all these cells in a couple different spots in the biopsy, then the diagnosis is pretty easy. And we do have these other stains that can help us if we wanted to give us an idea of what fraction of all the cells in the biopsy were mast cells, or to do CD25 like we talked about. But if all the other criteria have been met, then you can make the diagnosis without doing some of those stains.
So what is the real difference between mast cell, systemic mast cell disease and mast? I mean, I'm so confused with the difference. And what's the other one? It's just
Mast cell activation syndrome?
yeah. What's the difference?
So in patients with systemic mastocytosis, a pathologist really has to see those groups of cells in a bone marrow biopsy or a biopsy from a different organ like the GI tract or the liver. If you don't see those abnormal mast cells, but patients still have all the similar symptoms and they respond very well to these medications that will block them, then we call that a mast cell activation syndrome. Mastocytosis is when you have too many cells. When we have that osis at the end of a word,
it's too many.
There's too many cells. There's an abnormal growth of those cells, wherever it is. We have cutaneous mastocytosis when there's cells in the skin, and we have systemic mastocytosis when we can find those abnormal growths of cells in the bone marrow or in a different organ. And that's what the osis means. There's just too many.
So you can have just the right number of mast cells in your bone marrow, but they're shaped incorrectly, so then you have systemic mastocytosis.
That's a much more recent revelation. We didn't really know that before a couple of years ago.
We'll be finishing in about 5 minutes.
We used
so if you
to always
finish
need to
asking your
see those
questions.
groups of cells in a big clump to make the diagnosis. But now that we have some of these better markers, we can help make the diagnosis even on very few cells, as you said, as if they're long and skinny and if we do CD25 staining. But even in that situation, we still consider it to be too many cells. There's a growth of cells. In patients with mast cell activation syndrome, the cells look normal and they're normal numbers. So really, if you...
They look normal,
yes,
and you'll
patients.
find them always in the bone marrow. Everybody has them.
Everybody has them.
So in mast cell activation, they look normal and there aren't too many.
For the most part, yes. I think as a general
Generally
rule,
speaking,
that's true.
I understand.
So it's really a problem where the mast cells are releasing all their chemicals too much. And that's why we call it an activation. The mast cells are doing a bad job of getting activated inappropriately.
Okay, in mast cell, systemic mast cell, you just have too many of these things that are not acting right, and they're not shaped right.
They do the same thing. So in patients with systemic mastocytosis, those cells are doing the same thing as releasing all their mediators inappropriately at the wrong time. They're just doing it just off the cuff. They've decided to release them and you get really sick.
But do most people with mast cell activation syndrome have an elevated tryptase? Over 20? Or it's
Yes.
possible? And a negative Cicotte?
Yes. So there's
They usually have a
there's
negative
this gray zone, and this is sort of these
The
different
gray
words
zone,
that people are
yes,
using.
I
So
know.
I think Peter Valent or others have talked about like a monoclonal mast cell activation syndrome versus Dr.
clonal,
Aiken
like-
said idiopathic. Idiopathic often we
Gotcha,
use when we
okay.
don't actually know the cause.
Right.
If it's monoclonal, you can detect the Cicotte mutation.
Okay.
And we don't really know what makes the difference between mast cell activation syndrome without a mutation and mast cell activation syndrome with a mutation.
Gotcha.
This is all, we've only thought about these in the last few years, so this is a very, very new area.
Well, I have, my husband and all my kids and my father-in-law and we all went through NIH, and they did his bone marrow biopsy, but that came out negative. But they all have DA16B, whatever, negative, or it's not positive. But they all have elevated tryptase levels, 20, and autoimmune disorders that sort of run concurrent. Or my husband has worse autoimmune disorders, but it's familiar. There's 3 generations of 6 immediate family members.
Okay, everybody, I regret to tell you
And actually, I was
that
wondering,
we have
is there
to
any
bring
way
the
I could get
conference to a
his
close
bone
now.
marrow biopsy
I have
sent to
physicians that
you
need
so
to
you
get
can
home to
review
their
the slides,
families
at least
before the
just to
snow
see
hits,
what,
and we
I don't want to get
have,
any more further testing.
we
or
have members that
biopsies
need
or
to
all
get
that
home to their
stuff, but
families before the
it's
snow
just,
hits.
I don't know.
Thank
it
you
just
very,
seems
very
strange,
much.
and my daughters
We
are
have one
affected.
more auction.
No, sure. I mean, definitely you can get a second opinion on
Rita
pathology.
Lombardi?
It's very easy.
All right,
If you
and I'll
could
talk
come
to Dr.
forward, you
Castells
won
about
the
requesting
Western
it and
Monument
getting
of the Earthquake.
Sure.
They, both the girls suffer from
Photo, or
exercise-induced
it's a print.
anaphylaxis and physical
So if you
hives,
could
and they
come forward to
challenged them,
claim
put
that.
them in anaphylaxis and took out their blood serum. I mean, it was fine.
Two.
Clinical good, but it was kind of surprising just to find all this out. So I'd love for you to get their samples and at least just review it without having to put them through a bone marrow biopsy, which I don't think would be relevant if his was negative anyway.
Dr. Aitken was talking about getting families together.
Oh, my pleasure.
Yeah,
This
you're right.
anyway,
Oh, I
and
know.
be
Oh,
able
yeah.
to
I'm like, do you want a
participate
finger?
in that. Yeah.
I just
We
want some
need exactly that sort of stuff
Yeah.
to kind of start.
I know. The first thing I asked NIH was genetics and then outside. Everything is
It's not. Well, no, that's what the general belief is,
Oh, no,
but
right.
I don't
Not that
think
they're
so.
wrong, but
I really believe, and a lot of the doctors
and I get
don't.
confused.
They can only go with what they know at the time.
Yeah, exactly. That's what you've got to. You
I
can't.
had a bone marrow biopsy 4 years ago.
Wouldn't be the worst thing.
Right here. First on the
No, that's fine.
no matter.
Have a background.
Just all these other problems that all be tied in. I mean, I don't know what to say. And I'm from a little town in the church, and I just, you're basically, I just don't know. I mean, could all that affect, like, losing a brother?
Down there.